We're going to talk about now what we do to prep a patient for LASIK. And so when a patient comes in the doors at Vance Thompson Vision, Dan, what sort of testing are we getting? What's your standard refractive surgery or new refractive consult look like here?
Yeah, I think there's a whole bunch of testing that we do. One thing that I really want to focus on that we've been using a lot more is epithelial mapping.
Oh, yeah.
I think, and we can talk more about some of the other tests that are really should be standard, pentacam or some sort of corneal tomography, in my opinion, is standard now. Like, you can't do LASIK without doing tomography. I think some of the dry eye testing we're doing is also really important, but epi mapping.
And I'm gonna pause you. Can you differentiate topography, tomography, and why tomography specifically is important?
Yeah, I think tomography is more important because it gives us a view of the back side of the cornea, and the back side of the cornea is where a lot of the early keratoconic and ectasia changes happen. Now, some might even argue, well, the first changes actually happen in the epithelium, then it's the posterior cornea, then it's the anterior corneal curvature. And so I think that is why epithelial mapping, for a couple of reasons, has been so huge for us. If you have anyone who's on the fence, because either their anterior cornea looks a little bit steep and you say, is this an early keratoconus, or is this contact lens overwear, or is this, occult EBMD, and they look steep in an area and you get the epithelial mapping, if they're thin in the steep area, very suspicious for keratoconus or an ectatic process. And it's some studies show that that's the first thing that happens. If you have an area that there's thinning over that steep area, and that's one of the first signs of keratoconus.
Okay, quick poll. Of the three of us here, who thinks the first sign of keratoconus is a thinning epithelium? Raise your hand.
Yeah.
Who thinks it's ectasia on the posterior cornea?
For people just listening, all three of us raised our hands on epithelial thinning. So nobody else.
It's a huge point, because that's why I think epithelial mapping is. I'll let you continue, but I think epithelial mapping is going to become standard of care because of that point that you just made.
Yeah,
I've got a whole slide deck of patients where because I like to pull it up. I'll pull up the Pentacam and I'll say, well, would you do LASIK on this patient? Yes or no? And then I'll flip over the epithelial mapping. And epithelial mapping has pushed me one way or the other multiple times. It'll make me a lot more comfortable doing a LASIK procedure on inferior steepening because I see that inferior epithelium is thick. So if I see that, why would we do LASIK? Why not just be safe and do PRK? Well, that inferior epithelium that's thick, if we wipe that away and do PRK, they're not going to be happy because it's going to grow back a little bit more uniform. Now we've treated astigmatism that's no longer there. Now we're doing a fine tune, and a PRK fine tune's not fun. And so there's a lot that goes into that. And then on the flip side, I've seen patients that actually look pretty good. Maybe the Pentacam, it doesn't look bad. And before I had epithelial mapping, I would have done LASIK. But boy, I get that epithelial map, and it's actually 45 or 40 over that cone, and it's maybe a light PRK, maybe we're monitoring kind of a situation, and so it's pushed me both ways.
Yeah, that's a good point, Brennan. Really, we rule in people just as often as we rule them out, and both are important. We have people who get sent to us that have said, "Oh, you have keratoconus; they should be cross-linked," and we look at their epithelial mapping, and it's not keratoconus. It's thickening. So I think that's really how we kind of can screen for ectasia and things like that. Doug, how else are you using epi mapping? So we can screen people in, we can screen people out. What else? How else is it helpful to you?
The other way I'm using it is I'm using it a lot more. I know we're talking mainly about LASIK, but LASIK applies when we're thinking about doing enhancements or fine tunes on advanced cataract patients after their cataract surgery. And so I'm starting to work up the cataract patients that are opting for a diffractive multifocal implant. If we're going to have to do possibly a corneal fine tune on them because we don't hit the target, then I want to make sure that epi mapping and corneal thickness and curvature and everything and dry eye wise, that I'm okay with them having a corneal fine tune afterwards if we're not going with a light adjustable lens. And maybe then I might even find something that's a reason for me to switch in that decision of which IOL we're going to choose with the cataract. So I'm using it in our cataract patients. I'm also using it in our enhancement decisions. So I'll have, we had a patient here a few weeks ago, had LASIK done almost 8 or 9 months ago, pretty moderate myope, 5-diopter myope or something, came back in. I think they were maybe a year out. And right eye was 20/20, 20/15, left eye was 20/30, refracted at a -1, and young 32-year-old couldn't figure out why one eye was all of a sudden undercorrected, because he said he started out pretty good. Did an epithelial mapping, and his epithelium was like 68 in his that left eye, and in the right eye was like 52. And so he had an epithelial hyperplasia in one eye, and that was the epithelium that had caused that. And so eventually we may be able to go in and fine tune him, but if you had just come back and said, oh, I think we'll just do a fine tune, and you didn't know the reason why that was happening, I'm using it a lot of times for enhancement decisions now also.
Yeah, especially a PRK fine tune. I had a buddy
Yes.
tell me
Yep.
this week. He said, "Hey, man, I had a patient. He had LASIK a few years ago. He regressed back to a -1. He's like, I'm really leaning towards doing a PRK fine tune." And I said, "Boy, can you get an EpiMap? Because if that epithelium's 65 and you're going to do PRK and it comes back 50, he's going to be unhappy for the next 1.5 to 3 years for the epithelium to hypertrophy." So I said, you better so I said, number one, you need to get an EpiMap on that to decide if you're going to, lift the flap or if you can get away with a little PRK. But
And
yeah,
the epithelium
okay, so
might not have hyperplasia the second time. That's why it's unpredictable.
Right. You don't know.
So if you would just have treated the epi, you might have got him back to plano. If you'd have treated the epi plus ablated him, you probably would have left him a +1 or something. And then he's, like you said, unhappy. And so I think it's really, really been a key part of our change. Maybe, and then I think we're doing a lot of dry eye testing that is so important. And the reason is, there's a lot of studies now that have shown, even in patients who are asymptomatic, putting them on an anti-inflammatory like a cyclosporin, in addition to the steroids before and after the surgery, really can help with some of those symptoms. I mean, Doug, what are kind of some of the things you're doing every day for dry eye treatment for LASIK, and how are you working them up?
We're working them up. We're doing mammography on them on most all of our refractive patients. I want to know what their meibomian glands are doing. At the slit lamp, you're looking at their lids, pushing, pulling, squeezing. I'm doing all that, like a full workup for a dry eye patient when I'm thinking LASIK. As I'm sitting at the slit lamp, I ask them, are your eyes normally pretty comfortable? So I have 3 questions I ask them, and most of the time it's at the slit lamp, and it's to help me with all the rest of these tests that I'm doing. As I'm at the slit lamp, I'm saying, are your eyes normally pretty comfortable? And they're going to tell me whether they're have dry eye symptoms or not, or they're comfortable or not. Second, do you rub your eyes or do you sleep with your face in your pillow? So then I know whether there's any mechanical thing that they're doing that could affect that epithelium or affect their flap or their cornea long term. And if they're rubbing their eyes, then we have a discussion about that. And then third, those patients that fall into the late 40s to early 50s, my third question is, how's your nighttime vision? It's the poor man's glare test. And so it gives me some information about how much are they bothered by any scattered light, because then I have a little bit of an approximation from their perspective of what their lens is doing to them. And then we're doing all of the dry eye testing. I do a lot of punctal plugs. We do a lot of meibomian gland treatment. We do a ton of immunomodulators, whether it be cyclosporin or lifitegrast. We're doing a lot of that treatment preoperatively for patients with LASIK, and I don't think you can over treat anybody prior to their LASIK. And I have a lot of patients who have no symptoms and don't measure very much, and I'm still being fairly aggressive at treating their tears. Use a lot of temporary collagen plugs day of LASIK just to give them an extra 3 to 5 weeks of extra tears. We do a lot of that as well.
Yeah. Yeah, and I'm usually, having the conversation with the patient too. Usually my conversation about dryness, and I, tell every LASIK or tell any LASIK or refractive surgery patient, I say, hey, dry eyes after any eye surgery is not uncommon. Okay, it's pretty normal. We know, because dry eye after LASIK is one of the most studied things. And I say, dry eye after LASIK is real. And the other thing we know is in the vast majority of patients, it's temporary. Now, everybody heals differently. Whether it's 3 days, 3 weeks, 3 months, it's a little bit different. But generally that dryness goes away. And if not, we can treat it. But chronic dry eye after LASIK is something that we don't see a ton of.
Especially if they've been properly screened and they don't have
Exactly.
pre-existing,
Exactly.
maybe that's very good. If they don't have pre-existing dryness that was missed, it's really uncommon to have de novo permanent dry eye disease after having a, normal LASIK surgery.
All right, so last thing I'll touch on the before, and then we'll transition to the after. But the before, the other thing that we do is see and do LASIK. So see and do LASIK is where we live in a geographically spaced out part of the world, right? And so we'll get patients that drive 3, 4, 5, 6 hours to have LASIK or refractive surgery with us, and we trust the eye docs out in the community to make these good referrals on folks who want LASIK. And so a see and do LASIK is where we get a good referral in from a doc. And I think the most important piece of that is being cyclopleged with cyclogel or cyclopenolate, so a true cycloplegic refraction. And then we can call and talk to the patient beforehand. And then we do a LASIK consult that morning and usually do LASIK later that day or that afternoon. And so we can kind of bunch everything up together. And that just helps out folks, instead of making 2 4-hour trips, they can make 1. And in those patients, I've canceled see and do surgery before, right? And so we're not afraid to stop the momentum on those things. And so it's a great way to take care of our community.